Hi, my name is Chris Sutton, and I'm going to be performing my number 6 video airway of emergence, or PACU. So first things first is I'm going to do my machine check. I'm going to check my pipeline pressure, make sure it's at least 50 at least 50 psi, and I want to make sure there's no crossover as well. I'm also going to check my E-tanks, make sure that they're at least halfway full with the key available. My ambu bag, suction. I want to make sure I have my apples, my rescue meds, as well as extra airways. I want to check my flow meters and my Link 25, make sure those are both working well. And I also want to do my low pressure check. And that's going to involve my flow meter and as well as my vaporizers, make sure there's no leakage there. I'm also going to make sure my vaporizers are full enough for this case. I'm going to turn on my AC power, make sure there is power, and I'm going to go ahead and calibrate my O2 sensor, and I'm going to check my CO2 absorber, make sure that it's not exhausted or desiccated. I'm also going to check my standard monitors, make sure that they're at the appropriate settings, as well as my ventilator settings are at the appropriate settings. I'm going to check my ventilator valves and make sure that they're working appropriately, and I'm going to perform my high pressure check. Okay, I'm going to make sure my APL valve is all the way off, all the way closed at 70, and then I'm going to include my white piece, and then I'm going to flush. I'm going to use my O2 flush. Oh, I have to change it from ventilator to manual mode. I'm going to push my O2 flush and increase my pressure to about 30 centimeters H2O, and make sure that that holds for at least 10 seconds. And it looks like it does. All right. Okay, now we're going to move on to our patient here. We have a 19-year-old female coming to the OR for a left ACL repair after a college soccer accident. She has a BMI of 22, her height is 165 centimeters, and she weighs about 60 kilograms. The labs that we want to draw are CBC, BMP, PT, or INR, type and screen, as well as urine, HCG, and a chest x-ray. We then performed an airway assessment and found that she has a Malapati score class 1. She has a thyromental distance of 3 fingers. She has an upper lip bite, class 1, and tear incisor distance of 3 fingers. Her neck length or girth is within normal range. Her neck range of motion, she has full range of motion. And I also went ahead and auscultated her heart and lungs, and those are within normal limits. I communicated with the surgeon, and we both discussed that for this patient we want to use use regional anesthesia support to improve post-op mobility and pain control. We also want to do rapid emergence so that the surgeon can assess motor function and pain soon after surgery. Also want to make sure we may have that nausea and vomiting postoperatively under control. So for the physical assessment, some of the things that I asked her was if she had any medical problems such as lung, heart, or stomach problems, any previous surgeries, had she had any problems with anesthesia in the past, or her family, and also if she or her family had any issues with malignant hyperthermia. Also if she has any known allergies, what medication she's taking, what she had for breakfast. I also assessed her cardiac physical. I also did a cardiac physical assessment to see if she's able to climb 2 flights of stairs without limitations, and if she can walk 2 blocks without limitations. And after performing this, I found that she is appropriate for this procedure and for anesthesia. For the plan, we want to perform a regional adductor canal block as well as an IPAC block, and then wheel her to the OR, pre-oxygenate the patient, and then give induction medication. And we're going to intubate with an LMA and then provide general anesthesia. Okay, so we have the left 20 gauge in the forearm, and we are going to give our induction medication. Before I give the induction medication, I'm gonna give her some midazolam, 2 milligrams, and then I'm also going to give her 8 milligrams of Decadron. And then we're gonna go ahead and do place the adductor canal block and IPAC block. And I'm just going to verbalize that, and we're just going to say that it was done. And now we're going to transfer her to the OR. And now that she's in the OR, we're going to connect her to the standard monitors. We're going to connect her to her pulse ox, EKG lead, 3 lead, and a non-invasive blood pressure cuff. Now I'm going to go ahead and I'm going to mass ventilate her for at least 3 to 5 minutes with 100% O2. And I'm going to use this spider strap so that I can have, let's connect her back up. We don't want to disconnect that. So that I have more hands available. Sorry, just having some issues getting this ready to go. Okay. All right, we're gonna pre-oxygenate her with 100% for at least 3 to 5 minutes. And after we've done that, we're gonna go ahead and give her induction medication. So I'm gonna give her 100 mics of fentanyl, and I'm gonna give her 120 of propofol. That's based off of 2 milligrams per kilogram. And then I'm gonna give her succinylcholine, 60 milligrams. That's based off of 1 milligram per kilogram. All right, so now that she's slipped into stage 3 anesthesia, I'm going to go ahead and take off this face mask, this mask ventilator, and then I'm going to intubate her with number 4 LMA. All right, so we're going to take this off, and I want to make sure that my LMA is well lubricated. All right, and it's going to be partially deflated. I'm going to use the anatomy of the mouth to kind of guide it through, and I'm going to use the scissor technique. All right, this looks like it's in the right spot, and I'm going to go ahead and inflate that. Then I'm going to connect her to the ventilator, and I'm going to manually ventilate. And so I'm going to check for ET. I'm going to check for end-tidal CO2 waveforms. I'm also going to assess for chest rising, and I'm also going to auscultate for bilateral blood cells. I also want to make sure that I tape her eyes shut. That should have been done after induction. So I'm going to go ahead and do that now, and we're going to secure the LMA in place. Okay, and then I'm going to turn on her volatile gas, sevoflurane, to 1.8%, but I will titrate it down based on the patient's clinical presentation, knowing that that she has a successful regional block. I've confirmed the airway. She's been positioned to a supine with arms out and with her left affected leg supported. So for her maintenance, I'm just going to titrate her gases as needed. Okay, so for emergence, we are going to do a deep emergence for this case. Near the end of the case, I'm going to give 4 milligrams of Zofran to treat postoperative nausea and vomiting. So my sevoflurane is currently at 1.5%, and the patient still appears to be in stage 3. I've confirmed that that she has spontaneous ventilation, spontaneous breaths, breathing, regular ventilation, good tidal volume, and good vital signs. So I'm going to make sure I have my Airway-Emergence and reintubation equipment ready. I'm going to pre-oxygenate my patient with near 100% O2 for 3 to 5 minutes, and I'm going to provide thorough suctioning. Okay. Suctioning, she's been suctioned, and now we're going to perform a gentle ventilation. Okay, I'm going to deflate my cuff. We are going to extubate our patient here, and then I'm going to insert an oral airway. And I'm going to also use that as a light block too. And then we're going to immediately mask ventilate our patient here. Okay, so our patient is being mask ventilated. We're going to do that with 100% O2 for at least 3 to 5 minutes, and then I'm going to monitor her closely, and then we're just going to assess for spontaneous breath, spontaneous breathing, and she appears to be stable. And so now we'll go ahead and transport her to the PACU on 2 liters nasal cannula. So I'm going to take my face mask off, keep the oral airway in, and we're going to go ahead and put the nasal cannula on. And then we'll go ahead and take the tape off. All right. So now and then upon arrival in the PACU, I do want to make sure that she is connected to a pulse ox, EKG, and a non-invasive blood pressure cuff. Okay, so now that we're here, I'll go ahead and give report to Nurse Daniel. So this is Angelica Schuyler, a 19-year-old female with no known allergies, no significant medical history, who underwent a left ACL surgery lasting about an hour under general anesthesia with a left adductor canal and IPAC block for analgesia. Airway was secured with an LMA, no difficulty noted, 20 gauge IV in her left forearm, stable intraoperatively and currently stable postoperatively. Minimal blood loss. She received 600 mils of LLR, 100 mics of fentanyl, propofol 120, and 60 milligrams of succinylcholine. Was also given 4 milligrams of Zofran for post-operative nausea and vomiting prophylactically. Her last blood pressure in the OR was 118/70, heart rate was 65. Her pulse ox showed 99%, and on 2 liters nasal cannula with a temperature of 36.5. And neurologically, she's been opening her eyes to noise, but not following commands yet. Orders have been placed for IV fluids, PRN pain meds, orders have been placed for IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. Do you have any questions? That's my presentation.